and welcome to the Alabama Public Health Training Network. I am LaShawna Stodgehill, a respiratory care clinical coordinator at the Pediatric Pulmonary Center at the University of Alabama, Birmingham. Thank you for joining us today for our program, Improving Lung Health in Patients with Sickle Cell Disease, Alabama Perspective. This program is supported in part by the UAB Pediatric Pulmonary Center grant from the Health Resources and Services Administration of the U.S. Department of Health and Human Services sources. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. If you have a question about anything being discussed today, please email during our broadcast. The email address is on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on April 13, 2024. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our faculty presenters today. First, we have Dr. Amar Sadoun, Assistant Professor in the Division of Pulmonology and Sleep Medicine at the University of Alabama at Birmingham. Dr. Sadoun is a pediatric pulmonology attending physician at Children's of Alabama. He is a graduate of the University of Mosul College of Medicine in Iraq. He completed this residency and his fellowship at UAB. Dr. Sadoun is also the medical director of the Sickle Cell Disease Pulmonary Program and the Pediatric Pulmonary Hypertension Program at Children's of Alabama. He is a clinician scientist. Dr. Sadoun's research focuses on pulmonary complications of sickle cell disease, including clinical, translational, and basic research. His laboratory studies the risk factors and therapeutic targets of acute chest syndrome and pulmonary hypertension. Joining Dr. Sadoun, we have Lauren Burks-Moore. Lauren is a young lady with sickle cell disease who will discuss complications of sickle cell disease from her own perspective. Welcome. I know you both have a lot of important information to cover today, so let's go ahead and get started.
All right, so thank you so much, LaShawna, for the very nice introduction. And I appreciate the invitation from the Alabama Department of Public Health to present here in Montgomery today. And I also appreciate the help of the Pediatric Pulmonary Center at UAB for funding this activity that is helpful for everybody. And I thank Ms. Lauren Burks-Moore for being my co-presenter today to talk about the patient side of my presentation. And my presentation today, as you heard earlier, is about how we can improve the lung health of patients with sickle cell disease, especially here in Alabama. So I'll go ahead and start. And as LaShawna said, if you have any questions, you can just submit them, and we'll try to answer those questions at the end of the presentation. I don't have any conflicts related to this presentation. And over the next 1.5 hours, or a little bit less than that, we'll try to cover those objectives. So I will first review the pulmonary complications of sickle cell disease and their impact on patients with sickle cell disease. And then I will try to discuss the state of research of those complications and clinical care with a special focus on the state here in Alabama. Then we'll listen to Ms. Berksmore to talk about the patient perspective of sickle cell disease, especially when it comes to the pulmonary complications. And then I will give you some idea about the role of the pulmonologist in the care of sickle cell disease and how this can improve the care. So we'll go ahead and start. So sickle cell disease is the most common blood disorder that's inherited genetically, and it's autosomal recessive disease. So you need to get the genes from both parents to have the disease. And it results from a change of single base from the adenine to tyrosine, and this will change the type of the amino acid from glutamine to valine, and this in turn will change the type of the hemoglobin from the hemoglobin A, which is the most common type of hemoglobin when we do the analysis, to hemoglobin S, or the sickle hemoglobin. And the sickle hemoglobin is the main reason why the red blood cells will change when they're exposed to low oxygen saturation. And it is considered a rare disease by definition. However, it affects a huge number of people. Here in the United States, it affects more than 100,000 people, and it affects more than 20 million people worldwide. And about 1 out of 365 African Americans, they have the disease, and 1 out of 13 are carriers of the disease, or they have sickle cell trait, which is the other name of carrier of sickle cell disease. The diagnosis of sickle cell disease recently, over the last 5 to 10 years, has been done through newborn screening. So most patients with sickle cell disease are diagnosed at birth as part of the newborn screening. And this gives us an opportunity, both care providers and families, to intervene early into the disease to improve the outcome of this disease. So this is a great chance for us to improve the care of sickle cell disease and improve the life expectancy and quality of life. Speaking about life expectancy, as you can see from this figure, over the last 5 decades, there have been significant improvement in life expectancy in sickle cell disease with all of the advances in the modern medicine that you can see listed here. However, even up until now, the gap in life expectancy between patients with sickle cell disease and the general population here in the US is still huge. We need to work harder to get this gap to narrow with time. And not only the life expectancy is decreased, but the quality of life is also affected by the disease and its complications. Because most of patients with sickle cell disease, they have chronic pain, chronic respiratory issues, anemia, and they need to come to the hospital frequently to take care of those complications. And this can affect their life quality. And looking specifically at Alabama, this is a study that was published in 2015, and it looks at the incidence of positive newborn screening for sickle cell disease with the different genotypes of sickle cell. And as you can see in the top, Alabama, compared to the other states, has pretty significant impact of sickle cell disease with high percentage of newborns tested positive for sickle cell disease. And this is true also for the rest of the states in the southeast that are marked with the red rectangles here. It seems that this area is highly impacted by sickle cell disease, so a lot of effort needs to be spent to help reduce the burden of this disease, especially in the southeast of the United States. And those are the numbers of the positive newborn screening tests and the number of sickle cell disease in the different counties of Alabama. And this is a paper that was published from UIB back in 2016. And as you can see, as you'd expect, that counties with a higher population, they have higher number of sickle cell disease. And that's what our program tried to focus the effort in. So our program, which is the UIB and Children's of Alabama Sickle Cell Disease Program, it's a lifespan program, meaning we take care of patients with sickle cell disease from birth until their late adulthood. And it has multiple components. It has a clinical and research components. It was established in 1995, and an interim study 5 years after the establishment showed that it improved the outcomes of sickle cell disease significantly here in the state. So although the numbers doubled over those 5 years period, the outcomes of those patients improved by 90%, especially when it comes to mortality. And the program has an adult side, which is in the green at the top, and has a pediatric side at Children's of Alabama in the orange on the right side. But it also includes 3 satellite clinics to serve people in the counties that are most highly impacted, as you see. The pediatric side of this sickle cell program includes more than 1,200 children with sickle cell disease that are seen both in the clinics at baseline and for follow-up, and also they're admitted to the hospital at Children's of Alabama when they're sick with any of the complications. Our sickle cell disease pulmonary program, which is part of the lifespan comprehensive sickle cell disease center at UAB, started in 2017, and it has 2 components. One is the clinical and the other is research. The clinical part includes the sickle cell disease pulmonary clinic that's held twice a month, and we see all patients with sickle cell disease and underlying lung health issues to improve their outcomes. But it also includes an inpatient side, which includes consults with the sickle patients admitted to the hospital, especially with lung issues like acute chest syndrome. The clinical part also includes the acute chest syndrome clinical pathway, which we will talk about in a few minutes. We'll see how this has improved the outcomes of our population in Alabama. And recently, over the last 2 years, we started the pediatric pulmonary hypertension program that includes sickle cell disease as one of the main population that we follow and try to prevent pulmonary hypertension and treat it if it happens. The second part of the program is the research part, which is very important because this is how we can answer the questions that we ask usually when we see the patients in the clinic and in the hospital when they are admitted. And this research part has a clinical part and has a basic part, which is the laboratory part. The clinical part started first at UAB and Children's of Alabama, but over the last couple of years, we have been collaborating with nearby centers, especially in the Southeast, with the states listed here, because as we said, those are the states that are impacted by sickle cell disease the most, to try to have collaborative effort among all of us to improve the health of people with sickle cell disease. On the laboratory side, I lead the laboratory research for sickle cell disease, and we're doing both basic and translational research to get to know why patients with sickle cell disease, they have lung issues and how we can treat those. So we'll start to talk about sickle cell disease and the lung effect of sickle cell disease. And as we talked earlier, when you have hemoglobin S here on the top, this hemoglobin is very sensitive to low oxygen. So when the oxygen drops down, so if the oxygen saturation normally is usually upper 90s, when patients with sickle cell disease, they get sick, their oxygen can drop down to like in the 80s or lower 90s. And when this happens, what happens is the hemoglobin will change from the normal structure, which is soft circular structure, into like needle-like structure that you see on the right side with the drop of the oxygen. And when this happens, when the hemoglobin S polymerized, we call it, what happens is 2 things. One is that the shape of this red blood cell would change from the discus round shape into the sickle shape, and that's how the name of the disease came from. And that's what you see on the right side here. And the other thing that happens is those cells will be prone to rupture or hemolyze, we call it. And that's what you see on the left side because of this needle-like structures inside the red blood cells. So both of those things, the sickling of the cells and the rupture of the cell, will lead to subsequent effects. And what happens is when you have sickling on the right side, those sickled cells will block the blood vessels and prevent the blood from coming to vital organs, and then those organs will start to get sick and get damaged gradually. The other thing on the left side, when the red blood cell rupture, it will release all of those toxic substances that were inside the red blood cell. And both of those, the sickling and the blockage of the blood vessels and the release of those toxic substances, will lead to inflammation of the different organs of the body and damage of those organs. And what happens is usually this vicious circle of interaction between the red blood cells in the blood and the lungs. So when the lungs get sick for any reason, the oxygen saturation will drop down because that's what the lungs do, is provide the blood with oxygen. And then this low oxygen will cause the red blood cells to sickle and rupture and hemolyze. And this will cause further damage to the lung, and the lung will get sicker, and then we'll go into this vicious circle. So we will talk a little bit first about how sick lung will affect the red blood cells. And I hinted to this a little bit. So the lung is the main source of the oxygen. So if you have lung dysfunction, there will be a desaturation. The oxygen saturation starts to drop down. And this will lead to the sickling and rupture of the cells, and this will lead to the lung damage. So normally the red blood cells should look like this. They're round and discoid. When the oxygen saturation drops down, they will change to the sickle side and they will rupture. And then both the sickling and the hemolysis, they will lead to damage of the different organs of the body. But those are the main organs that are affected that you see here. So the lungs will have the acute chest syndrome and chronic lung disease that we'll talk about right now. And we have also a risk for developing stroke and brain issues, risk of acute kidney injury and chronic kidney disease, risk of pulmonary hypertension and systemic hypertension as well. So all of those are consequences of low oxygen and sick lungs. Now, there is very good hope for the future with new developments in medicine, as we talked about earlier. And now we have curative therapies for sickle cell disease, meaning that after those therapies, people with sickle cell disease, they will not have sickle cell disease anymore. They are still in the early stages, but for the stem cell transplant, it's pretty in advanced stage, and it is in the clinical use in many centers all over the states, including our place. And Dr. Goldman in the hematology division is leading the effort to do a transplant for patients with sickle to cure them from the disease. The new promising therapy is the gene therapy, which fixes the gene defect that causes sickle. And it's, as I said, it's still in the early stage, but the results are very promising, including this study that was published recently from UAB, from here. The primary author was Dr. Julie Cantor from the adult side. And what you see here is the gene therapy that was started in the middle with the gray line. And on the left side, the red dots that you see for each individual patient, those are severe episodes of pain that required admission to the hospital or ED visit or starting on opioid. And then the gene therapy started at the gray line, as I said. And after that, we followed those patients for anywhere between 6 and 24 months, up to 36 months after the gene therapy. And as you can see on the right side, at the yellow side, there are no more red dots, meaning that those patients who received the gene therapy did not develop an episode of severe painful crisis after the gene therapy. So this is very promising. So in this era, while we're waiting for those therapies to be in clinical use and safe, our job is to try to keep people with sickle cell disease as healthy as possible and to keep their organs healthy and functioning. So when they get this curative therapy, they will have normal life expectancy and life quality afterward. And that's what we are trying to do. Now we'll talk to the other side, which is how the sickling can affect the lung health. How come the sickled cell can cause the lungs to be sicker? And this is because lungs get 100% of the cardiac output, meaning all of the blood that leaves the heart goes to the lung. And it's the only organ that gets 100% of the cardiac output. And this can reach up to 35 liters per minute of blood during exercise. So anything in this blood can affect the lung, including the sickling and the toxic things that are released from him during the hemolysis. The exchange area of the lung is huge. It's like the size of tennis court, and it's very thin, extremely thin. And that makes it very vulnerable to any toxic things in the blood. So with time, if you have anything that's injuring the lung, with time you'll have progressive injury to the lung if you don't do something active. And you can appreciate how thin this layer between the blood and the air in the lung by looking at the figure in the right bottom. And compared to the red blood cell, which is pretty small, the air-blood barrier that we call is extremely thin. So this makes it very vulnerable to anything in the blood. Now we'll shift gears to talk about the state of the research about sickle cell disease, especially when it comes to pulmonary complications. And unfortunately, we don't have a strong research of this specific area. And those are the two statements of the mostly highly respected institutions. One is the American Thoracic Society in the bottom, and the other one is the American Society of Hematology, or ASH, at the top. And as you can see in the guideline, they mentioned that the recommendations are not that strong because the evidence that we have is not that strong as a result of this. So this is the most important factor, probably why we don't have a strong evidence about the research in sickle cell disease. And this is a paper that was published in JAMA end of last year, also from here, from UAB. And it compares 3 genetically inherited diseases, the sickle cell disease, cystic fibrosis, and hemophilia. They are all nasty diseases that can affect life expectancy and life equality. And this paper tried to compare the 3 conditions in terms of the research side and the funding. And as you can see, I highlighted the sickle and cystic fibrosis because sickle cell disease, cystic fibrosis is very dear to my heart, and I have been taking care of cystic fibrosis patients all my life. And I see the importance of research and the advances in this field. And I would like to see the same with the sickle cell disease. So if you see the number of patients with sickle cell disease in the United States, they are much higher than the cystic fibrosis patients. However, the centers of excellence to take care of sickle cell disease are much less. The most striking difference is in the funding on the right side. If you can see that the funding per person of sickle cell disease is much less than that of cystic fibrosis. So our job as clinicians and providers is to support this population in terms of our clinical care, but also to advocate for them to improve the research and the funding of this population to find curative therapies sooner. And the other reason why we don't have a strong research when it comes to lung disease of sickle cell is because we, as pediatric pulmonologists, are not that involved in research of sickle cell disease, lung disease, because we have huge population of other disease conditions that keep us busy all the time, just like asthma, BPD, cystic fibrosis, and patients on vents. So I think we need to pay more attention to this population to improve their lung health. And I think it's fair to say that if we support the sickle cell disease research and clinical care, we can participate in decreasing the health inequity when it comes to chronic genetically inherited diseases. So now we will go into the main subject of the presentation, which is the pulmonary complications of sickle cell disease. And those are four of the most important complications. The list is long, but those are the most important complications that I will try to cover over the next 1 hour or so. So we have acute chest syndrome, which is a very acute condition that's associated with some high morbidity and sometimes mortality. And then we'll talk about sleep disorder breathing and low oxygen saturation. And then the asthma and abnormal lung function in sickle cell disease. And then pulmonary hypertension, specifically in sickle cell disease. So I will start with speaking about the acute chest syndrome. And the reason why I started speaking about this, because acute chest syndrome currently is the most common cause of death in children with sickle cell disease here in the United States and the rest of the first world countries. And it usually affects young children, like toddlers. It peaks usually between 2 and 4 years of age. Sickle cell disease patients, when they develop acute chest syndrome, they will be more prone to have recurrent episodes, especially if they develop early in age. And that's why about half of all patients with sickle cell disease, they will develop at least one episode of acute chest syndrome. It's pretty prevalent and has very high recurrence rate. And acute chest syndrome can develop during the admission for other reasons. So about half of the patients who develop acute chest syndrome, they're usually admitted with painful crisis first, and then they progress into acute chest syndrome while in the hospital. So they don't come with acute chest syndrome right away from home. And that's why we need to pay attention to patients who are admitted to the hospital with painful crisis, because they may progress into acute chest syndrome while admitted to the hospital. Now, how do we diagnose acute chest syndrome in patients who come to the ED or they're in the hospital or even to the clinic? We have to have very high level of suspicion about acute chest syndrome in order to diagnose it. Because if you don't think about it, you may not diagnose it early enough to prevent it from getting really bad. And the current acceptable definition of acute chest syndrome is if a person with sickle cell disease comes with acute respiratory symptoms that are listed here, in addition to a new infiltrate on a chest X-ray. Meaning they will come with like cough, fever, shortness of breath, wheezing, and then you do a chest X-ray because you are suspecting an acute chest syndrome, and you see a new infiltrate in the chest X-ray that was not there before, then you can say that this patient has acute chest syndrome. We are trying to add another major criteria for the definition, which is the low oxygen saturation, just because it's very important in the pathogenesis of acute chest syndrome. And it has been recently added to the definition by ASH, by the American Society of Hematology, fortunately. So if the patient comes with very low oxygen saturation in addition to respiratory symptoms, even if they still don't have any infiltration on the chest X-ray, we can still diagnose them with acute chest syndrome. And this will help those patients by diagnosing them early, as we will talk about in a minute. Physical exam is very important, and those are the things that we usually focus on. So, of course, vital signs and oxygen saturation, just because we know how important low oxygen saturation in the beginning of the process and in the continuation of the process of acute chest syndrome. And then, of course, we have to look for the source of pain and listen to the heart of the patient. And then we usually do those tests for patients who come with suspected acute chest syndrome, including chest X-ray, which is a mainstay in the diagnosis. So all patients with suspected acute chest syndrome, they should get a chest X-ray, and we prefer to do 2 views, AP and lateral, in order to pick any infiltrate that may not be seen on the AP view, which is usually the most common view that we do initially. We also do those other tests. So we do a CBC, we do type and match in order to prepare for blood transfusion in case the patient needs it. We do the hemoglobin S percentage because this is one of the goals of especially exchange transfusion, is to bring down the hemoglobin S to a certain level to improve the outcomes, in addition to the other tests that are listed here. There are some tests that we don't do them on every patient, but just individualized, the ones that you see in between the brackets. And those tests are indicated in certain situations if patients show some signs and symptoms. And now we'll talk about the acute chest syndrome risk factors. So typically patients with acute chest syndrome, they come with an infection, most commonly viral infection, especially in children, that will lead them to develop acute chest syndrome. This is a case scenario about acute chest syndrome and how things develop when patients come to the hospital. So this is a patient who is this is a real patient that we saw in the hospital. She's a 9-year-old with hemoglobin SS. She had a history of acute chest syndrome in the past, admitted to the hospital, including PICU admission, and she also has a history of asthma. And this is important, as we'll see in a minute. She came to the ED with acute respiratory symptoms and some chest pain. And they did a chest X-ray in the emergency department. The one on the right, I put the one on the left as a baseline. This is the chest X-ray that was done 3 months prior to the admission, to the presentation to the ED. And as you can see, compared to that one on the left, the one on the right, there is infiltrates, especially on the left side. Normally the lung should be black, so when you see this white thing, it means that there is infiltration in the lung. So there is a new infiltrate on the left. With her presentation, she was diagnosed with acute chest syndrome. Over the next 24 hours, she progressed, and as you can see on the x-rays that there are more infiltrates on the left side, but also there are new infiltrates on the right side. And then we were consulted, like the pulmonary service were consulted because she was getting worse. The afternoon of that second day of admission. And this is the time that we went to see her, and she was intubated at that time. So they put her on a ventilator because she could not breathe on her own. And then on the same day, that night at 11 p.m., she was put on ECMO, which is a kind of artificial lung machine that will take the blood from the body, oxygenate the blood, take out the CO2, and then get the blood back into the body. And she continued to be on the ECMO machine for more than 3 weeks. And this is her last X-ray on day 25. And unfortunately, we lost her after that chest X-ray. She got really worse, and the PICU team couldn't bring her back. So our goal is not to hear this story again. And this is why we're doing this presentation and we're doing this program and seeing the patients. So no more children with sickle cell disease will die of acute chest syndrome, hopefully. Now, what are the risk factors for acute chest syndrome? And as we talked about, if you have high level of hemoglobin S, then you'll be at high risk of sickle cell complications in general, including acute chest syndrome. The opposite is for hemoglobin F or fetal hemoglobin. The higher level of fetal hemoglobin, the better the prognosis is. Also, there are certain genotypes that are worse than the others. So hemoglobin SS and S beta 0, they have worse prognosis than, for example, hemoglobin SC and beta plus. We also have other risk factors, including high white blood cell count at baseline, will give you high risk for acute chest syndrome. If you have an asthma, then there is a high risk of acute chest syndrome by about 2-folds. And then exposure to secondhand smoking is a very important factor that increases the risk of developing acute chest syndrome. So this is a very important point to pay attention. And when we talk to patients in the clinic or when they're admitted to the hospital, is to try to avoid any exposure to cigarette smoking or vaping. Those are some of the other risk factors for acute chest syndrome that can make things worse or increase the risk of patients to develop acute chest syndrome. And one of them, the last one that you see, is using opiate, especially during admission for painful crisis. Because if you overuse pain medicine, this may cause hypoventilation, and the oxygen will go down, and this can predispose patients to acute chest syndrome when they are admitted for painful crisis. Now, how acute chest syndrome is triggered? So we have patients that are more prone to have acute chest syndrome, but how it starts. This is the largest prospective study of acute chest syndrome in the United States back in the 90s. And as you can see, about half of the time, we don't know what triggered the acute chest syndrome. The patient will start to have like shortness of breath and chest pain and cough all of a sudden without any apparent triggering factor. However, for patients who we know what triggered it, especially when it comes to children, it's usually infection. And for younger children, it's usually viral infections, just like cold or flu or COVID. And then bacterial infection. And interesting thing, that's usually atypical bacteria that can trigger acute chest syndrome more than other bacteria, including mycoplasma and chlamydia, and then the other kind of bacteria. Other triggers for acute chest syndrome, including asthma. So if patient has a history of asthma, they have asthma flare, this can be the beginning of acute chest syndrome. That's why it's very important to diagnose this asthma exacerbation early into the course and intervene early to prevent it from progressing into acute chest syndrome. The other reason is fat embolism and pulmonary embolism. The fat embolism usually happens after painful crisis. So when you have pain, you have necrosis of the bone marrow, and there will be release of fat from the bone marrow that can go into the lung and start the acute chest syndrome process. How patients with acute chest syndrome present? As you can see, this is the same prospective study that we talked about, the North American sickle cell disease group. And as you can see here, most of the patients come with chest pain and shortness of breath, and they can have pain somewhere else in the body. Those are the most common presentation. For the other large prospective study, they found that fever also can be a presenting symptom in addition to the pain and shortness of breath. But those are the most common symptoms. That's why they're included into the definition of acute chest syndrome. Now, this is our perspective as care providers, physicians, nurses, respiratory therapists, social workers in the hospital. When we see people with sickle cell disease come to the hospital with those complications. Now, we will listen from Ms. Lauren Berksmore about how is sickle cell disease from the patient side and how people live with sickle cell disease. So I will move the presentation to Lauren to talk about her side of the story.
Hello, everyone. Thank you for allowing me to be here and talk about my story. Thank you, Dr. Sadoun, for giving me the opportunity to. So, a little bit about me is that I'm 19 years old. I attend the University of Montevallo, and I'm going into a nutrition major. I like to cook, bake, draw, anything creative, to be honest, anything that involves my hands. I like to cater, and I've been doing it for a couple of years and taking baking classes, etc., just for experience. But overall, I have sickle cell, or better known as hemoglobin SS, which is the most severe form of it. When I was younger, it mostly shown as swelling of the joints or pain around my joints. And very frequent, most likely I would have fevers and coughing and wheezing. Other than that, my life was pretty normal, or what I consider it to be normal for me. Even through middle school, having to go through hospitalizations over and over, I still got to do normal things that every other child got to do, like go to camp, swim, do sleepovers, hang out with my friends, until freshman year of high school happened. It was Thanksgiving break, and I really don't remember much. I knew I was making tornado potatoes, which are really great. I had put them in the oven at that time and went to rest on the couch. After that, everything kind of escalated from there. I apparently fell asleep, and I wasn't very responsive. My mom noticed me having nasal flares and labored breathing. When she checked my O2, it was extremely low, and she used my sister's oxygen to, well, just so we could get to the emergency room. For the next 72 hours, it's kind of step by step. They found out I had acute chest syndrome in my left lung, which affected my right lung to have acute respiratory distress. And after that, it proceeded to have a ventilator, and I got bilateral chest tubes. And for that, I was in the ICU for about 6 weeks. Around Christmas, they had took the ventilator off me and put a trach inside of my neck. I basically had to relearn everything over again. What helped me the most, though, when I was on the ventilator was that they like to pancake me. So I didn't do well in breathing on my back. So they would put me on my stomach and I would do significantly better. I don't know. But basically, throughout those 3 months, I had to relearn to walk and talk and everything over again, especially when you love to draw and you have to relearn how to do that all over again, which was really devastating. Talking was extremely hard as well, because speaking with a trach was extremely difficult. Other than that, early 2018, I got discharged eventually, and when I went home, I had teachers that came over to help me learn everything and get my academics back. I was able to graduate with my class as well, so I didn't even get held back. Around the fall, my trach was removed, and I had slowly started going back to school regularly. I had received a report for monthly blood transfusions as well. Oh my gosh. Moving forward, I, as you know, graduated high school. I also received multiple scholarships as well. Leadership and academic, which was very surprising. I thought it was a joke at that time. Magic moments through the whole situation in ICU in those 3 months that gave me the chance to go to New York and visit and learn how to build my catering and baking skills as well. Even through the whole situation, my friends were still there and supported me, which was very great because I needed the support. My goals are still to have my own culinary business and baking business using the knowledge that I gained from nutrition as well. And I plan on doing a few internships to build my portfolio as well. I did want to say thank you to my mom for supporting me. And throughout that hard time, I know it was hard as well on her. And the doctors and nurses for aiding me and helping me get back to health, even when many of them didn't think I would make it. And thank you, Dr. Sadoun, for giving me this opportunity to share my story. And I think that is it. Thank you, everyone.
All right, that is super impressive, Lauren. I'll give you like just round of applause. Yeah, that's very nice. This is like, it's heart touching, like the way that things change all of a sudden, and then how you came back from this. It gives an idea to the people about how resilient you are and how you recovered completely, and you do all of this like very amazing achievements afterward. This is really impressive. And this is inspiring to everyone, I think, including ourselves. And this makes us feel very happy about what we do and encourage us even to do more, because we see that what we do and how we help is giving some results. Thank you so much, Lauren, for the presentation. That was very nice. And as I told you earlier, your slides are amazing. They make me feel bad because my slides are boring. So I'll try to improve my skills. I may need your help and consultation just like you did one time. So just for you all to know, Lauren told me how to make those graphs in the presentation, the dynamic ones. So she was in the hospital, in the clinic, she was getting some pheresis transfusion. And she told me, like, she told me about how to do the figures and how to make them move in the presentation. So she has great skills, and she will have a great future. And Lauren is transitioning soon to the adult side, so we will miss her a lot on the pediatric side. But I told Lauren and the family that we will be there all the time if they need any help, or if they have any question, or if the providers on the adult side they have any question, we'll be there to help. All right, so I think I'll move ahead with my boring slides to finish the presentation. And then at the end, if you have any questions for me or for Lauren, please let us know. All right, so we talked about the acute chest syndrome and how we diagnose it, and then we listened to Lauren about what happens during those acute chest syndrome from the patient perspective. Now we'll talk about how we treat those acute chest syndrome episodes in the hospital to try our best to improve the outcomes of those episodes, meaning to decrease the length of stay in the hospital, decrease the chance of developing acute respiratory failure, requiring ICU admission or bedding in the vent, or ECMO, or trach. So we usually look at the most updated information in the literature to see what's out there, what is the most updated things that can improve the outcomes of acute chest syndrome. And in addition, for our mission, when we started in 2017, our mission was to do research ourselves to try to improve those outcomes by researching ourselves. So this is the current kind of state-of-art management steps in acute chest syndrome that we are following at Children's of Alabama. The first one is analgesia. So it's very important to treat the painful episodes very early and adequately from the beginning in order to shorten the course of the stay and prevent the disease from progressing into acute chest syndrome. Because what happens sometimes if you delay the treatment or if you don't treat it early, then the pain will continue to be there and cause more hypoventilation and cause more acute chest syndrome. And now we have a protocol in the ED to start pain treatment down in the ED. It's led by Chandra Blackmore in the ED, which is a very good program. And then after we control the pain, the next important step is the respiratory support for patients with acute chest syndrome. And this includes the steps that are listed here. So the first one is the oxygen supplementation, which is the key thing to keep the oxygen on the high side. So typically for other patients, we would like the oxygen to be 92% and above. But when it comes to sickle cell disease patients, we would like it to be 95 and above. And the reason for that, because if you keep the oxygen on the high side, even tissues that don't get a lot of blood, they will get enough oxygen to prevent further sickling. So we would like the oxygen to be on the high side. We also start some respiratory therapy interventions, usually start down in the ED. That's what the protocol recommends, the one that we have right now. And then we start some bronchodilators, especially in patients with history of asthma, or patients without history of asthma, but they come with wheezing. And when you listen to their chest, then those therapies, the bronchodilators, can help open the airways and improve the oxygenation of the blood and prevent further sickling from happening. The other thing that sometimes we need to use is support of the breathing with non-invasive ventilation, so CPAP, BiPAP, AVAPs, or sometimes invasive ventilation with a ventilator. And in some situations, just like the scenario that we talked about, some patients require ECMO if they continue to get sicker despite being on the vent. The next important management step is antibiotics, because as we said, most of those episodes are triggered by infections, although a lot of them are viral in children, but you cannot exclude bacterial triggers for those acute chest syndrome episodes. So usually we start with antibiotics that cover acute chest syndrome as a result of community-acquired pneumonia bacteria. So typically we start with ceftriaxone and azithromycin, but for sicker patients we usually add vancomycin to cover MRSA and Streptococcus pneumoniae that's resistant to ceftriaxone. And then the next thing that we usually start patients with acute chest syndrome is fluids. And with the fluids we need to be very cautious, because dehydration itself can make things worse, because the blood will be more viscous and they'll be more prone to have obstruction of the blood vessels in addition to the sickling. But overhydration, giving a lot of fluids, can also prolong the stay in the hospital, as was demonstrated in this study. So we need to keep the fluids at 1 to 1.5 maintenance for the first 24-48 hours, and after that we should be able to wean the fluids down as the patient start to drink more liquids. But we should always follow the vital signs and the weight of the patient to make sure that they're well hydrated but not overhydrated. Then transfusion is very important, especially if you have low hemoglobin. You can give simple transfusion for patients who are not that sick with mild acute chest syndrome. But when patients start to get sicker, that's when we do exchange transfusion by putting a central line, getting the blood out of the body and giving a new blood that has less hemoglobin S in order to decrease the sickling that's in the blood. So those are the main kind of therapies that we use for acute chest syndrome. As you can notice, all of them are kind of supportive therapy, but we don't have any targeted therapy to the kind of process that starts the acute chest syndrome so far, because again, we don't have a lot of research in this area. And now we'll talk about the acute chest syndrome clinical pathway that we studied at Children's of Alabama about 3 years ago. So the reason why we use special clinical pathways and protocols, because it has been proven over time that if you start certain protocol or bundle of treatment that includes standardized therapy for any disease process, you can improve the outcome of that disease process. And the reason for that, because you'll use all of the updated recommendations to treat that disease process, and you'll have all of those steps at the same time given to the patient. And instead of leaving it to the provider who will decide which treatment you need to give and may delay some of the treatments or so on. So our pathway was based on a couple of publications at least that proved that starting clinical pathways in patients with acute chest syndrome improve the outcomes. And those are some of the outcomes that improve. And the reason is we usually diagnose acute chest syndrome early in the disease process with the pathway, and also we start this respiratory therapy interventions like the incentive spirometry, PEP, vest machine, or other interventions early into the course, in addition to the hematology intervention like transfusion. And also, and this is important, is to have some objective scoring system that will follow the patient on regular basis. Usually every 2 to 4 hours we do scoring of the respiratory status of the patient, and if we see that this score is going up, meaning the patient is getting worse, then we can step up our treatments to get the acute chest syndrome under control. So this is the acute chest syndrome protocol that we started at Children's of Alabama a few years ago, as I said. And it's pretty detailed protocol, and it has all of the updated information, and we review it every year to make it newer and make it more updated. And it includes 2 parts. The first part is the ED part, the one in the top. And this includes all of the steps about how you diagnose with acute chest syndrome in the upper part, and then what are the steps that you need to do next. And then the scoring, which is the clinical respiratory score, the CRS. And based on the score, how sick the patient is from the score, this will decide the disposition of the patient. If the patient needs to go to the floor or to the step-down unit or to the intensive care unit. And all of those steps are associated with order set in the electronic medical records at Children's. So the physician, as soon as you put acute chest syndrome diagnosis, it will bring down all of those things. So you can just check those interventions that you need to start for the patient. So all of those things will start at the same time to try to improve the condition of the patient. The second part is the floor part. So this part is what will happen after the patient goes into the floor, whether it's in the hematology side or the special care unit or the PICU. And each one of them has different kinds of order set, depends on the severity of the patient, and is associated with electronic medical record orders. First, it makes things easier for the providers to order all of those extensive orders, but also it will improve the outcomes of the patients because you will apply all of those at the same time, and then it's a dynamic process. So you change those orders as the patient is getting sicker, you step up the treatment. If the patient is getting better, you'll wean those treatments down to expedite the discharge process if the patient is improving. This is the respiratory score that we use for this pathway, and includes 5 parameters, and each one of them is scored anywhere between 0 and 2. So the total score will be anywhere between 0 and 10. And normally it should be 0, but for mild acute chest syndrome, you can get 1 or 2. If you get to 3, it means that you have a moderate. Anywhere 5 and above, this means that this is a significant acute chest syndrome episode. And the first 3 criteria, they're similar to those used in the asthma pathway and the bronchiolitis pathway that we use at Children's of Alabama to make things easier for the respiratory therapists. But the last 2, which is the CNS status and the oxygen saturation, those are specific to sickle cell disease because those are very important to determine the severity of acute chest syndrome in sickle cell disease patients, but they are not as important for bronchiolitis and asthma. So this is the scoring that we use at Children's based on our population and our system. And in order to test the effectiveness of this pathway, we did an interim analysis after 2 years of starting the pathway. And as you can see from this figure on the left, on the x-axis, you have patients who were with acute chest syndrome who were placed on the pathway on the right, and on the left is patients with acute chest syndrome who did not go on the pathway. And on the y-axis on the left, this is the length of stay. And you can see clearly that patients who went on the acute chest syndrome pathway on the right, they have much less length of stay, so they spend less time in the hospital before going home than patients who were not on the pathway. So it's about like 4 days versus 8 days for patients who are not on the pathway. And then we looked at the time spent after the chest x-ray done until the discharge from the hospital, just to make sure that we correct for patients who are diagnosed while admitted to the hospital and they didn't come with acute chest syndrome to the ED. And we had the same results. Patients who are on the acute chest syndrome pathway on the right, they have much less length of stay while in the hospital. There are other improved outcomes as well, including the ICU admission was much less, the mortality was less in patients who were put on the pathway. So far we know that this pathway is helpful and is improving the outcomes of those patients. We are trying to involve more and more patients into the pathway when they're admitted with acute chest syndrome. Now, we will move to the lab side. So we talked about the clinical side and what we are doing in the hospital. Now we'll move to the lab. And one of the main goals that I had when I started the program is to have a model, an animal model of acute chest syndrome, so we can see if any of the therapies that are available or new novel therapies can help improve the outcomes of acute chest syndrome so we can use them for our patients. And in order to develop a model of acute chest syndrome, I used 2 ways. This is the first way, which is exposure to chlorine. So as you know, chlorine is released when you use cleaning agents, when you clean something at home, or when you go to the swimming pool, they use chlorine to prevent spread of infection while swimming. There are studies that have shown that if you are exposed to those cleaning agents frequently on daily basis, there is a chance that you have a decline in lung function. And this is a study from Scandinavia that followed people who use cleaning agents at home versus those who use it in their job as part of their profession to use cleaning agents. And they compare them to smokers, and they follow their lung function, and they found that especially women who use cleaning agents frequently at home, they have a faster decline of lung function than control women, and it's comparable to women who smoke. So it was pretty alarming. And similar kind of study was done in Canada, and they followed children from birth until they are 3 years of age. And they looked at children who are exposed to cleaning agents at home, like their moms use cleaning agents frequently at home versus those who don't use. And they found that those who are exposed to more cleaning agents by the age of 3, they're more prone to have asthma and wheezing and other outcomes. So we thought if those agents, the chlorine, can induce some sort of airway disease, can it induce acute chest syndrome as well? Because asthma increases the risk of acute chest syndrome. So what we did is we used, we called it humanized mice. So those are mice that had their hemoglobin, the mouse hemoglobin gene taken out, and they inserted a human hemoglobin gene in the mice. So they produce normal human hemoglobin. So their red blood cells produce hemoglobin A and S that's in the similar to the human. So they show the same phenotype of people with sickle cell disease and normal people with normal hemoglobin. And this mouse was first produced in the 80s by Dr. Tim Towns, who is at UAB as well. So he's the one who produced the first humanized mouse by knocking out the mouse gene and knocking in the human gene here at UAB, and it has been used all over the world for the last 20 years or so to research acute chest syndrome and other complications of sickle cell disease. So I've been fortunate to work with Dr. Towns and get those mice from his lab to do the experiments. So what we did here is we exposed some of the mice to chlorine on the right side, both mice with sickle cell disease and normal hemoglobin. And then we followed those mice for 6 hours. And we checked on them every half an hour to make sure that are they sick or not. And then at the end of the 6 hours, we euthanized the mice to look at their blood, their different organs, to see what's the effect of chlorine on them. And this was surprising for us. This is a survival graph, we call it, or Kaplan-Meier graph. And it compares how many mice were like alive by the end of 6 hours after exposure to chlorine. And the red line on the top is the normal hemoglobin, the control mice. The one in the at the bottom, the blue line, is the sickle mice. And you can see with time, a lot of mice started to die after exposure to chlorine. And so after 4 hours, only about 35% of the mice were alive. About 65% of the sickle mice died, while the normal mice, all of them, they were alive at the end of the experiment. So this is was very alarming for us. This means that sickle mice are very prone to chlorine exposure. And when we looked at why those mice died, when we did the analysis, we found that they have very severe lung disease, similar to acute chest syndrome that happens in humans. This was shown in the histology on the left graph. You can see on the top, these are the room air exposure. The one on the bottom is after chlorine exposure. And you can see the congestion and cellular infiltrates. And we did a scoring. It's called the acute lung injury score on the right figure. And you can see the one on the right, which is SS, which is the sickle. The blue line is after exposure to chlorine. And you can see the score went up significantly high, which means their lungs got like super sick after exposure to chlorine. And when we looked why this happened, we found that the hemoglobin dropped down significantly after exposure to chlorine, which means that those mice develop hemolysis, their cells just ruptured after exposure to chlorine. And when we looked at what happens to the red blood cells, we found that there will be increased red blood cell fragility. So red blood cells, even with minimal stimuli, they will rupture easily after exposure to chlorine. And we found that there is significantly increased level of heme, free heme, which is one of the things that are released from the red blood cells when they rupture. And heme is very toxic to the tissues and cause injury and damage to the tissues. So we thought that the overall kind of conclusion was those mice died because they have rupture of their red blood cells because of chlorine exposure. And these ruptured blood cells release the heme, which is toxic to the tissues, including the lungs, causing this acute lung injury and death, and acute respiratory failure. So we thought, if this is the case, what happens if we give some medicine that can clean this heme from the blood? And this is called hemopexin. And hemopexin is normally secreted by our bodies, but the level is very low in the body, and it cannot cope with the high level of heme that happens with the hemolysis. So what we did is we repeated the same experiment on only sickle mice, so we exposed them to chlorine, and then we divided the mice after exposure into two groups. One group, we gave them the hemopexin injection. The other group, we gave them just vehicle, which is all of the substances that are with the hemopexin injection except the hemopexin. And then we did the exact same experiment. We followed them for 6 hours, for 4 hours, and we did all of the analyses at the end. So as expected, at the end, we found that their heme level was significantly lower for those who received the hemopexin. And also the red cell fragility was less, meaning the cells were more resistant to hemolyze after you give them the hemopexin. So this was very encouraging. When we looked at their lung tissues, we found that the lungs of the mice who received the hemopexin, they look much better. They have less inflammation, less cell infiltration, and their score was much better. If you look at the right lower graph, the red one is the one with the hemopexin, and you see that the score was much lower, which almost equal to the control mice. And this has resulted in improvement of the survival significantly. So the blue line is the same line that we saw in the previous chart, which is sickle mice exposed to chlorine and received only vehicle. And the red line is representing the mice who have sickle cell disease exposed to chlorine but receive hemopexin. So as you can see, about 90% of the mice survived towards the end of the experiment versus only 35% of those who received the vehicle. So hemopexin was very helpful to prevent the lung injury in mice who develop acute chest syndrome and prevent the death in those mice. So this is the overall kind of theory that we have after this experiment is when sickle mice exposed to chlorine, they will develop something called chlorinated lipids, and we measured those in the mice who were exposed to chlorine. And those lipids will cause sickling and hemolysis of the red blood cells, and the release of the free hemoglobin that will then release the free heme from it. And this free heme will cause the significant injury and damage to the lungs on the left bottom figure. But if you give hemopexin to counteract the free heme, then you will save the lungs and you will not have as much inflammation. So we published this article in a very high impact journal, and it has been selected as one of the top articles of the year by NIH for the year of 2021 because of its impact. So that was very promising regarding this model. The other model that we're working on right now is using hypoxia, because we know that low oxygen can induce acute chest syndrome. So we thought, why don't we expose mice to low oxygen and see if they develop acute chest syndrome without injecting them or exposing them to any other things. So those are sickle mice with who are exposed to room air, so they're just in their cages. And we did a CT scan of the chest because that's how we diagnose acute chest syndrome, is by doing an X-ray or CT. And those are the CTs where they're under baseline condition. And then we expose the mice to low oxygen. And we notice increase in filtration, especially on the left side of all of the mice, similar to acute chest syndrome. And when we did the analysis by using this Hounsfield unit, which can measure how much infiltrate the mice have, those are the mice under room air. So you can see there is two peaks, one big peak on the left, which is the air peak, and the one small peak on the right, which is the fluids in the lung. So this includes the blood, some secretions in the lung. When we expose them to hypoxia, this is what happens. So the peak on the right increased significantly, meaning that there is more congestion, there is more blood, there is more inflammation in the lung of those mice. So this is another model that we can use to study treatments for acute chest syndrome for the future, and it's more kind of physiologic because it's close to what patients develop. And now, using those models, we are trying to find biomarkers for acute chest syndrome, meaning a blood test that we can do to diagnose acute chest syndrome early on, before they start to develop breathing difficulties and infiltration in the lungs, as we saw in our scenario. And we use the same model, the hypoxia model, to check those biomarkers. And those are microRNA, which are small particles that can code a lot of important biologic processes in our body. And we compared first on the left mice with normal hemoglobin to those with sickle cell disease. And we found that there are 3 microRNAs significantly increased in sickle cell disease. Then we exposed those sickle mice to hypoxia. And we found that those exact same microRNAs, they went up significantly even higher after exposure to hypoxia and development of acute chest syndrome, meaning that those microRNAs, they have important role in acute chest syndrome, or at least they can serve as biomarkers of acute chest syndrome, and we can just probably measure those levels, and we can diagnose acute chest syndrome earlier. However, this is a basic and translational research still, and we have to advance our research to the clinical side to test those biomarkers in patients. And then when we did the pathway analysis with the help of Dr. Gilling from the neonatology division at Children's of Alabama and UAB, we found that there are a couple of pathways that are activated very significantly early into the course of acute chest syndrome, and they are related to mitochondrial injury. So this is a comparison between normal hemoglobin mice and sickle hemoglobin mice. And this is in sickle hemoglobin mice after hypoxia. We found the same pathway and microRNA activated in both conditions. So those are very promising. And we have those results accepted for presentation in the coming American Thoracic Society conference in San Diego in May in one of the symposia about rare disease for the lungs. So hopefully this will alert people to this lung disease and will attract more researchers to this field in the future. So this is the main part of my talk, which is the acute chest syndrome. Now I will go over the other complications of sickle cell disease a little bit fast. So just so to let you know about what we do at Children's and UAB with those other complications. So next we'll talk about sleep disorder breathing and hypoxia. So we know that patients with sickle cell disease, they are more prone to have obstructive sleep apnea, and they have lower oxygen overall at baseline and also when they're asleep. So their oxygen saturation is usually on the lower side, and they have higher CO2, which means that the lungs cannot clear the CO2 from the blood as efficient as controls. So our question was, what is the effect of this low oxygen overnight on the outcomes of patients with sickle cell disease, especially acute chest syndrome? So this is a study was done by Dr. Noorani, who's a faculty in our division at Department of Pediatrics at UAB. And what he did is he took all of the sleep studies that were done at Children's and cross-matched them with all of our sickle patients that are seen at Children's, which are around like 860 patients. And he found about 110 patients who have sickle cell disease and sleep studies done. And we looked at 2 main parameters of oxygenation at night, the mean oxygen saturation all through the night, and then the percentage of the night that the child spent below 90% of oxygen. And then we correlated those with the possibility of having acute chest syndrome. And as you can see here, so when we looked at patients with acute chest syndrome versus those with no acute chest syndrome, we found that patients with acute chest syndrome, they have much lower mean oxygen saturation overnight. And we also found that those with acute chest syndrome, they spend longer time overnight with oxygen saturation below 90%. And so both of those indicate that there is an association between acute chest syndrome and oxygen overnight, which put an emphasis on oxygenation overnight. And then we tried to develop a model to see like at what level of oxygen will start to get concerned that this patient may develop acute chest syndrome in the future. And we found that with the mean oxygen, this is pretty high. It's 97% oxygen is pretty high. So patients who are with oxygen saturation, mean oxygen overnight less than 97.3%, they're more prone to have acute chest syndrome. However, the specificity was low. So we use the other parameter, which has high specificity, as kind of cleaning parameter. So patients who have spent more than 2.7% of the night, below 90%, those are usually at high risk of acute chest syndrome. So probably those patients need more aggressive intervention in terms of giving them oxygen overnight. Then we also started to study the effect of low oxygen overnight on the brain, whether those low oxygen overnight can affect the verbal comprehension and working memory later in life, because the brain develops very fast during childhood. If there is anything that can affect the brain development, it can have consequences later in life. So we looked at the sleep studies in our children, and then we did executive function analysis when they're teenagers by Tiffany Tucker and Dr. Mordo in the hematology division. And we found that those with lower oxygen during their childhood, they have more difficulty with verbal comprehension and other executive function when they are older. So it seems that oxygen is also important for the brain during childhood. So those are our areas that we will work on in the future, is to improve the oxygenation and see if this will improve the outcomes of sickle cell disease patients. Now the next subject is the asthma and lung function abnormalities in sickle cell disease. So patients with sickle cell disease, they are more prone to have asthma. And the prevalence of asthma in sickle cell disease is more than double that of MASH population. And we don't know exactly why this happens, but we know that almost half of patients with sickle cell disease, they have asthma. And we know that patients with sickle cell disease, when they have asthma, they're more prone to have acute chest syndrome, as we mentioned earlier, and also they're more prone to have pain. And this is probably because of the obstructive airway disease that would cause decreased oxygenation and more sickling. But this is just a theory that we have. And when we looked at our sleep study cohort that we talked about a couple minutes ago, we found that patients with asthma, they have 7-fold increased chance of developing recurrent acute chest syndrome than those without asthma. But this is just selective part, only 110 patients out of the 860 patients. So we try to look at all of our population with sickle, and we did this study is mainly to look at the effect of socioeconomic status on acute chest syndrome recurrence with the help of Dr. Oates, a faculty in our division as well. And what we found is patients with asthma, they're at like almost 3-fold higher risk of developing acute chest syndrome to have recurrent acute chest syndrome, in addition to the other findings of that study. Now, we do lung function on patients with sickle cell disease, but we don't know what to do with those lung functions. So we know from previous studies that patients with sickle cell disease, they are more prone to have obstruction of the airways. So their airways are narrower and tighter than controlled MASH controls. And we try to look like if this can affect the outcomes of sickle cell disease. And what we looked at all of our patients who have lung function, which are 150 patients. And we correlate this with acute chest syndrome. And what we found is patients with obstructive airway disease with lower FEV1 and FEF2575, which are 2 markers of obstructive lung disease, they're more prone to have acute chest syndrome. So the narrower the airways, the more chance that the child will develop acute chest syndrome in our population. And then when we looked at patients who have extensive pulmonary function tests, including all of the lung volumes and all of the other parameters, we saw that patients with sickle cell disease, they have signs of obstructive lung disease documented by a higher RV, which is residual volume, and RV over TLC, which is total lung capacity. And both of those are very sensitive markers for airway obstruction and air trapping. And also, we correlated those markers with the growth of those patients. And we found that it was interesting that children with sickle cell disease, they're a little bit on the shorter side during their first 4 years of life. And we don't know the reason for that. And then when we correlated the growth parameters with TLC, which is total lung capacity, which is a marker of lung growth, like how big their lungs are and how fast they are growing, we found that those with lower weights, when they are young, the first 4 years of life, they have lower TLC, which may be a sign that children who are malnourished or they're underweight when they're young children, they may have lower lung function when they get older, and their lung will not grow as fast. So this is another focus area that we are trying to investigate further in our center, is what if we support the nutrition of those young children with sickle cell, if this will improve their outcomes when they get older, similar to the cystic fibrosis population, that we know if we support their growth, they will have better outcomes when they get older. So this is another focus area that we will work on over the next months and years. And the last complication of sickle cell disease that I will talk about today is pulmonary hypertension. And the pulmonary hypertension in sickle cell disease is the group 5, which is the group of unknown cause or multifactorial cause. There are a lot of factors that can make patients with sickle cell disease more prone to pulmonary hypertension, and some of them are listed here. The important thing about pulmonary hypertension is that it is highly prevalent. About 1 out of 10 of adults with sickle cell disease, they have pulmonary hypertension, and it is associated with poor prognosis. So in adults who are diagnosed with pulmonary hypertension, the survival is about around 7 years after the diagnosis. And that's why we are trying to get more children to be screened for pulmonary hypertension, to diagnose it early and treat it early to prevent it from progressing into a irreversible stage. And this is the recommendation of the American Society of Hematology, is if patients show those symptoms of pulmonary hypertension, they need to be screened for pulmonary hypertension with an echocardiograph, and BMP. So those are the main two first steps to screen for pulmonary hypertension in sickle cell disease. And in Children's of Alabama and UAB, we just started our pediatric pulmonary hypertension program more than a year ago. And one of the first populations that were included in the program is sickle cell disease, in addition to primary pulmonary hypertension, BPD, and congenital heart disease. But sickle cell disease is one of the main populations that were started, and the goal is to improve the clinical care and the research of sickle cell disease pulmonary hypertension to improve the outcomes of those patients in the future. So hopefully our patients will feel the benefit of this program in the coming months and years. Now, the final part of my presentation is why I am a lung specialist pulmonologist taking care of patients with blood disease, and how the involvement of pulmonologists can affect the outcomes of sickle cell disease. And I talked about the importance of lung and oxygenation in sickle cell outcomes, but there are new studies coming about how involving pulmonologists can change the outcomes of sickle cell disease. This is a study that was published recently over the last few months, and it compared the healthcare utilization, meaning ED visits, clinic visits, and admissions to the hospital with patients with sickle cell disease before and after they started seeing pulmonologists in the clinic. And as you can see on the left, those are the number of times that those patients need to go to the hospital for acute conditions, and on the left side is after they saw the pulmonologist. And they found that the utilization decreased from like 4 times a year about to just 1 time a year after they started to see pulmonologists and improve their lung health. And they found that this is mainly because of early diagnosis of asthma and better management of asthma and hypoxia overnight. So if you diagnose asthma and manage it well, improve the hypoxia overnight, treat pulmonary hypertension, then all of the other complications of sickle cell disease, they will start to improve, and there will be less need to go to the hospital for this. So this is the conclusion of the paper, that involving the pulmonologist in the care of sickle cell disease can improve the outcomes of patients with sickle cell disease. And this is the model that we've been trying to build at Children's of Alabama and UAB to improve the outcomes of our populations. So what's our vision as a center at Children's of Alabama UAP for the future? We started to screen patients for pulmonary complications, like all patients with sickle cell disease, for all of those signs and symptoms of pulmonary complications, to try to diagnose those conditions early and intervene early. We're also doing a multidisciplinary approach of care, meaning the patient will be seen not only by hematologists who will manage all of their complications, but they will be seen by other subspecialists to manage the other complications, because this may improve the outcomes of the patients, as we saw in the last paper that we discussed. We are also trying to advocate to improve the research and funding of patients with sickle cell disease in order to decrease the health inequality. Also, as we talked about our clinical part and research, we have been trying to collaborate with the care providers and the researchers within the state and then within the region, the Southeast area, and to try to create a registry, meaning we have all of the information of our patients to see why they have the complications and how we can prevent this. And also we are trying to create a biospecimen biobank, which will include some samples like blood samples, urine, the lung air, exhaled air, to do more research about why patients with sickle cell, they develop these complications. So this is an effort in progress, and we're trying to collaborate with the neighboring states for this. And then we feel that improving this will hopefully, as we said, improve the health equity in the state and in the region. So the conclusion of this talk is we know that sickle cell disease is very common and it's a deadly disease. There is an interaction between the lungs and the sickle cell disease, and acute chest syndrome is the most common cause of death, but there are other complications. And we are trying to improve the healthcare and the research of sickle cell disease to improve the outcomes of those patients through multidisciplinary care and collaboration with the other centers. And hopefully this will improve the care of our patients and their life expectancy and health equity in the state. Those are the collaborators that work with me on the clinical and the research part, but the list is much longer than this. And I apologize for anybody who has participated and their name is not here. And this comes to the end of my presentation. Thank you so much for everybody who's listening and who's here. And I'm ready to take any questions.
We do have a question that has come through via email.
Yes.
And it's as follows. In regards to the oxygen requirements and immature lungs of preterm infants, how does their care differ from full-term infants with SCD? And are there different risks that needs to be adjusted?
Yes, this is a very good question, and it's a very complicated question as well, because it combines both prematurity and sickle cell disease. So there is a good thing and a bad thing about this question. The good thing is that when babies are born, the hemoglobin that they have initially is the fetal hemoglobin, hemoglobin F. So if when they are born, they're not at risk of developing sickle cell complications right after birth. And they're less prone to have sickling right after birth. They start to develop this when the hemoglobin switch from hemoglobin F, the fetal hemoglobin, into the sickle hemoglobin, which usually happens within the first 6 months of life. And usually by 6 months of life, most of the hemoglobin is hemoglobin S in sickle cell disease. So for the first few weeks of life after premature birth, they can be treated just like other babies without sickle cell disease who are preemie with the same goals of oxygen. So for extreme preemie babies, we usually aim for lower oxygen saturation to prevent the oxygen that can cause injury to their premature lungs. And then with time, we increase our goal for oxygen for them. So the good thing for sickle cell babies that they can be treated just like other babies without sickle cell disease in the first few weeks of life. Later on in life, we will be more generous with giving them oxygen. I'm talking about preemies with sickle cell disease, because first they will not be prone to the toxicity of oxygen, and then they will start to produce the sickle hemoglobin that can be sickled. So to answer the question, I would say the first probably couple months of life, we can just aim to the same goal of oxygen. But after 2 months of life, we can be more generous with the oxygen. We can aim for higher oxygen saturation in patients with sickle cell disease and prematurity.
Thank you for that. Well, this concludes our program for today. I want to thank both of our presenters for being here, and I want to thank the audience for watching.
All right, thank you, everybody.
Please remember that you can refer back to the training and resources anytime on demand. Have a great day.